Excellent. Good evening, everyone, and welcome to this Pituitary Awareness Month session, Living Well with Prolactinoma. I'd like to thank you all for attending this evening, and I'd also like to thank our speakers for giving up their time. You are in for a treat this evening, I will say that. This is one of the most subscribed events of Pituitary Awareness Month, so you really are in for a treat. Before we kick off, could I just say a huge thank you to everyone that has kindly supported this Awareness Month session through donating. This is a completely free event. However, if anyone is able to spare a few pennies to donate in this current climate, we would be very appreciative. I am delighted to say before we start that thanks to the support of Novo Nordisk, thanks to Conciliant Health, thanks to Merck, and thanks to a number of generous donations from our supporters, we've actually raised £15,730 through this campaign at the moment. And we've had a number of sessions which have gone really successfully. So thank you to each and everyone who's contributed. So before I kick off, just go through some basic introductions and housekeeping. So I'm Jay Shepherd, I'm the head of fundraising at the Pituitary Foundation. We have enabled closed captions, so if you'd like them, just click the CC button at the bottom. For those of you not familiar with the Pituitary Foundation, we provide support for the 70,000 plus people in the UK who are affected by pituitary disorders, as well as their families, friends and carers. We want to ensure that every person affected by a pituitary condition has a timely diagnosis and access to high quality treatment, information and support. We have a dedicated nurse helpline, online and printable resources, and we work with leading medical experts to improve patient care. I'm really excited to be having this talk as part of our Pituitary Awareness Month programme. For those of you who are not using visuals, I am white, early 40s, look far younger, navy jumper, wearing spectacles. The session will be recorded and will be available on our website later this year. No one's faces or comments will be visible unless you want to ask a question and have your camera on. We want to ensure all our events are welcoming and accessible for all, especially as we may explore personal experiences in this session. To this end, please can you remain on mute when not talking to manage background noise. You don't need your camera on if you'd prefer not, but it is lovely to see all of those faces out there who feel comfortable with it. You may wish to add pronouns to your name so we know how to refer to you. To chat, please either use the chat bar or raise your hand at the end when we get to the question and answer portion of the session. You will be spotlighted. Please be respectful as people share personal views and experiences, and this is recorded, as I've said, so please be mindful with colourful language. The session will finish around 8 p.m. But if you need to leave this session early, this is completely fine to do so. I'm now going to hand over to our brilliant speakers. I'd like to introduce Jessica Buck, who's a pituitary patient, Sherwin Criseno, who's endocrine nurse consultant, and the brilliant Dr Niki Karavitaki, consultant endocrinologist. Over to you, and thanks once again for giving up your time, folks.
Thank you, Jay. Thank you very much for the kind introduction. It is a great pleasure for me, and I'm sure for Sherwin, who will say hello as well, to join this wonderful session on the Awareness Month on pituitary, this tiny gland of 1 centimeter, as we all know, which is the master gland. And it is one of the glands that it is really rewarding to serve as a healthcare professional. So a very warm welcome from me too. I will ask Sherwin to introduce himself and say a couple of words, just to let you know that I work in Birmingham. I'm an associate clinical professor at the university here and an honorary consultant endocrinologist at the Queen Elizabeth Hospital. And I have the fortune to work with a wider team which looks after patients with pituitary conditions. So I would suggest that Sherwin says hello, then we have our Jessica, and then we kick off. Thank you.
Thank you, Niki. Thank you, Jay. And good evening to everyone. And thanks to the Pituitary Foundation again for inviting me and Niki to join your always very engaging sessions. And I can see some familiar faces and some familiar names. And I'm sure we're going to have an engaging session tonight, and we will try our best to answer your questions to the best of our ability. So all I can say is enjoy the rest of the evening, and we'll stay with you until the session ends.
Thanks, Sherwin.
Jess?
Would you like to introduce yourself, Jessica?
Perfect. Hi, everyone. Yeah, so my name is Jess. I will talk to you this evening just a little bit about me and my patient story. So you might know, some of you might know me, some of you might not, but I was actually diagnosed back in 2011 with microprolactinoma. Diagnosed by the lovely Niki, who is on screen with us tonight, and it feels really strange seeing Niki in person because I don't think I've seen her for about 10 years. So yeah, very, very small world. But I just want to really share a bit of sort of what happened initially, sort of 10, 11 years ago when I was diagnosed, what my symptoms were, and how I managed my condition and how I am now. So just to take you a little bit back to the start, I actually had quite a few symptoms that I wasn't sure, what was happening to me. I had constant sort of headaches, nausea. I was feeling very sick all the time. I actually had lactation from my breasts as well, which is something that I immediately thought I was pregnant. Being age 18, I just was, panicking. And after various tests and trips to the doctors and blood tests, I was eventually sent for an MRI scan, which confirmed that I had a microprolactinoma, so a very small pea-sized tumour on the pituitary gland in the brain. So that's when Niki obviously diagnosed me, and I was asked to try some medication. I was put on cabergoline, which is something that you might be familiar with. And I actually stayed on those tablets for about 5 years. They really, really helped with my symptoms. It made it much better to manage, made the headaches less frequent. I still had to kind of do quite a lot of blood tests every 3 to 6 months just to monitor my prolactin levels. And I also had to go to the eye hospital and have visual field tests and all sorts of things. But yeah, so the first, I would say sort of in just taking it back in the first few weeks after diagnosis, I did find that quite scary. And as a young 18-year-old, to be sort of hearing those words, you have a small tumour in your brain. I know it's benign, and unfortunately it's not cancerous and it's not sort of dangerous, but at that moment I was really scared and anxious, and I actually didn't know anything about the condition at all, and that's where the amazing Pituitary Foundation came in. That's where I found them. I do remember Niki giving me a leaflet from the hospital which had the Pituitary Foundation branding over it, and that's where I found the website, the information. I think there used to be some sort of online forums back in the day where I could search and look at online blogs, and that was just a lifeline to me, being young and not really having any other information out there. Yeah, which was amazing. So it was so great to sort of have that lifeline and speak to someone. And I think the charity are doing a fantastic job at getting the word out there, because 10, 11 years later, I know that thousands more people are going through similar things or having similar pituitary related illnesses, and to have the charity there as a mean of support is absolutely fantastic, and something that I've relied on a lot throughout my time, and have been fortunate enough to do some fundraising challenges with the charity, do some brilliant events and climbing Snowdon and things like that. So yeah, I feel very, very grateful and fortunate to be so well looked after. But it was a scary time, you know, pre-diagnosis and during diagnosis. So yeah, it's difficult. Yeah.
Thank you, Jess. That's a very, very informative description of the beginning of the story. So, so you were 18 years old. Have you ever heard of the word pituitary until then? No,
not at all. Not until you told me.
Okay, and then yes, the Pituitary Foundation did a fantastic job. But did you Google anything? Did you try and find out where is this gland? What is it doing?
Yeah, I absolutely. I did Google a lot at first before I actually found the charity and started using them for help. And I think a lot of the word around brain and tumour, as soon as you Google brain tumour, of course, the obvious things come up, things to do with cancer or things that are quite scary and quite dangerous. And actually, because I hadn't really fully understood at that time probably what my diagnosis was, I think that's what gets your brain kind of worried and thinking about all these things that it could be. But yeah, I absolutely did not know hardly anything about it. And actually, neither did my GPs. Before I came to see you, Niki, obviously a specialist in your field, my GPs didn't have a clue what was wrong with me. And that was what was quite frustrating, was I've been doing tests for months and nobody could tell me what was wrong. So I think that's where the education of knowing about the pituitary gland comes in massively. Because if the GP didn't know what was wrong with me, how was I supposed to know, you know, what was wrong or what was happening?
So you raise an important point, the awareness of conditions that could affect this tiny gland, and awareness not just from the public, because we wouldn't expect the public to know about pituitary gland, but even amongst the healthcare professionals, which is very important. And here is where the Pituitary Foundation and we as experts have to step in and try and educate. And so how long did it take from time zero is the first symptom that you experienced, until the day that someone who happened to be me, and I'm sure there are many other colleagues around the world who do that, who told you this magic word that it is a prolactinoma and it is not cancer? Okay, so what was the interval?
Yeah, I think it was to be honest, I think it was about 6 or 7 months before I actually met you, because I was going back and forth with blood tests or with just like doctors. At first, I think they thought that I had problems with my stomach, or like I've actually had other problems. I've had cysts on my ovaries, so they were more looking down that route, and they were thinking it could be more to do with that. That's why I had other symptoms. That's why I had the sickness. But actually, when I was lactating from my breasts, I think that's when they said, well, hang on, let's go and put you in touch with a specialist. It wasn't until I had my MRI that they actually found it anyway. So I think between all the tests and going back and forth and speaking to various doctors, before I was referred to the Churchill Hospital in Oxford, which probably took about 3 months to actually get a referral in the first place. Yeah, it's quite a long time. It was about 6 or 7 months before I, you know, from starting this symptom. And I used to come home from sixth form with tissue in my bra because I didn't know how to stop the lactation. And I think when you're 18 and you're thinking all these things, I just didn't know what to do. But it took me that long to be referred in the first place to the hospital. Hopefully now it's a bit better and they're a bit more aware of things. But I think, well, it was 2011, so 10, 11 years ago now. I don't think that awareness was there. And certainly my doctors was thinking it was other things before I was referred to yourself.
And the lactation, how did you find it? I mean, would your mind go to anything going wrong with your breasts, for example, you know, breast cancer, if I can use an extreme term? How did you find it?
I think those sort of thoughts were running through my head, particularly because I was so young and I just had no idea what this thing was. The first thought, like I said, was I thought I was pregnant, and after doing multiple tests and going back to the doctors like twice with 2, 3, 4 different pregnancy tests to say it's not that, what else could it be? I mean, I don't to be honest, I don't think kind of breast cancer itself sort of crossed my mind, because I wasn't sure that that was a symptom, but I didn't really know anything about it or why this was happening to me. And that's when I really just needed some help and needed some specialist help, and fortunately was able to be referred. But I think being that age, and I've since found out, you know, from the support groups that I'm with on the Pituitary Foundation, a lot of patients are a lot older than me. I know a few people that are sort of younger, and a lot of the patients in my local support group are actually sort of 50, 60, 70 years old. And I think they've really helped me to understand more about it. But particularly someone sort of my age, 10, 11 years ago, I didn't have anyone to speak to, because none of my friends are experiencing this. I never knew anything about my family experiencing it. And I literally had never heard of it. So I remember feeling really, really overwhelmed and feeling a little bit alone, and just had no clue what this was until I was able to speak to the foundation and just get some information from them. So I honestly can't thank them enough for being there for me.
Great. Sherwin, any question?
Yeah, thanks for sharing your experience, Jessica. 2 questions. One is for the benefit of the audience here, patients with the same condition, and one is for me and Niki's benefit. Yeah. So the first question is, if you are to go through that process again, or if someone in the future will go through that process from the point that they're having symptoms and diagnosis, what 2 key things did you find the most helpful for you that you were not aware of and you just discovered along the way? And if you have known that from the very beginning, you would have accessed that straight away. So what 2 most important things you would advise those people to make their journey better? So that's my first question.
I think the first thing would be that I had no idea. Oh, thank you. I think the first thing would be that I had no idea that this was something that was actually hormonal. I thought because I was physically leaking up from my breasts and I had physical headaches and blurred vision, I very much thought it was, well, it's my headache, it's my eyes, you know, I thought it was something very, very physical, which I couldn't see. But the fact that it was a hormonal condition, and it's invisible, nobody can see this. I've said this before, to look at me, you actually probably wouldn't think there's a problem. But if I'd have known it was a hormonal condition, the first thing I would have done is contact my GP and said, let's do more blood tests than you think, or hormonal tests, or something else that isn't just a standard blood test, because I'm sure when they did the initial blood test, nothing would have come up because they weren't looking for my prolactin levels. They had no idea really why I was the way I was. So I think the first thing would be to ask the advice possibly of the GP. You know, I think this could be something hormonal. I think could you run tests on certain areas, because I definitely think that would have narrowed it down quite a lot quicker.
Okay, so for me and Niki, throughout your journey, what do you think we could have done better to make your journey even better for you?
Oh, that's really hard, because Niki was so amazing when I first met her and got diagnosed. And I think she gave me answers when I had so many questions. And that's the thing that I found so helpful. And I remember my mum coming in the room with me, and she just came out and said, oh, we finally got an answer, Jess. Like, that lady was amazing. And, you know, I think obviously fantastic. I don't know, the only thing I change in hindsight is being diagnosed sooner. And it's not you guys that have led to that. It was unfortunately just my GP had no idea what to do. But maybe it's the awareness of local GPs and walk-in centres before it gets to the hospital stage. I feel that is where improvement is needed.
So I guess the take-home message for us and Niki is to do a bit more awareness, and a session like this is an awareness session for patient and public, and what we'll be focusing probably are awareness for non-specialists, which are something that we are thinking of considering in the future. But as Niki mentioned to you, your condition is rare, and it's not something that your GP will think straight away, because there's so many thousands of different conditions that your GP will have to think of before even considering some hormone. But that's something that we'll take on board, and something we'll consider in terms of our future plan for engaging non-specialists and educating them. Niki, that's all my question.
Thank you. So yeah, for now, indeed. So as you said, you started cabergoline, and I assume cabergoline led to normal prolactin, and we expect also shrinkage of the tumor, so a dual effect. did you experience any side effects on this medication?
Yeah, so initially I just remember having really low moods and feeling really upset all the time and really sad, and then the next day I'd feel really happy and excitable. And I do remember my moods being quite a problem, particularly for the first month or so. It was quite kind of up and down, and I know I was adjusting to having this new medication. I think right at the start I suffered with a bit of sickness. It was sort of a bit of nausea and that kind of thing, but it settled down quite quickly. It wasn't until I took my first blood test post being on the medication, which I think would have been about 3 months in, that they actually said, you know, your levels are coming down, that's great, we'll just continue on this and monitor you in another 3 months or 6 months and then go from there. So it absolutely did its job, and it did what it was meant to do. For those first 5 years, it certainly reduced it massively, and I lived a relatively normal life. Well, many people won't know me, but I've traveled across the world. I've been to Australia, America, all across Europe, and I've thankfully been able to live a really full life, and I haven't let it hold me back at all. But there were struggles initially. There were those sort of the initial sickness and the low moods, and the sort of uncertainty, I guess, that comes with being on a new tablet for the first time.
Mm. And it seems that you had a relatively successful journey, I would say. Of course, not easy, but successful, because the treatment has worked. How do you see your future now? I see that it hasn't, this condition, the prolactinoma, hasn't stopped you from being active, positive, and well. So how do you see your future with quotation mark what was told to you a brain tumor, which is not as horrible as it sounds, as a prolactinoma?
Absolutely, yeah. No, I've had, like I said, a really normal and fulfilling life, and I'm happy and healthy, and I'm very, very grateful. I've had sort of, in the last year, I actually have come off the medication. I came off the medication last August, just because I'm at the stage where I'm thinking I might want to have children in the future, and I was sort of advised by my consultant last year, let's see how you are without the medication, because being on the medication, you're not very likely to be able to get pregnant, or you're kind of not really supposed to be taking the cabergoline if you're planning a baby. So I actually had a conversation last August with my consultant, and she actually said, well, why don't you come off it for a year and let's see how you go. My prolactin levels did go up naturally without being on the medication, which I understood was going to happen, but they sent me for an MRI last month, and I'm waiting on the results. So I actually don't have them at the moment. So to answer your question, I'm feeling great. I feel this is the first time I've been off the tablets for like nearly 10 years. So it's great. And it might be, I mean, the best possible outcome is that the MRI shows the tumour has reduced or not changed, in which case I probably will stay off the meds for a bit longer while I decide what I want to do about having a family. But in the worst case, if they've shot up again and the tumour's grown, of course, I'll put myself back on the medication. And then I will just stick with that for another few years until I decide when I want to have children. So yeah, I see my future very much. It's kind of, it's at the moment I'm waiting on results, which is a weird position to be in, because that's the first time I've had an MRI in about 6-7 years. But I know once I've got that, I can make a decision then for my future and think, okay, well, for my health and well-being, I don't want to be a mum right now, and I'll go back on the tablets. Or if I do decide in the next year or so I want children, then I will stay off them for a bit longer. And naturally in pregnancy, obviously your prolactin levels will go up anyway, so I understand that will happen. So yeah, it's just a bit of a strange time to be thinking about it, but I am where I am at the moment. It's good. It's just waiting for some results, and then I'll decide what to do.
What to do, which means that you take, I mean, you contribute to decisions for your care. You're part of the team that decides about your care, aren't you?
Yeah.
Which is good, I guess.
Yeah, I guess so. Yeah, in a way. I mean, I'm kind of making the decision myself now under the advice of the consultant. So that's always quite nice. You know, I think when I was initially diagnosed by yourself, it was very much this will be the medication for the foreseeable, or until you have children. At 18, I was thinking, okay, well, that's miles in the future. So to have been on tablets for 10 years is a long time anyway. I guess back then I thought, God, I'm going to be on it for 50 years. And I know I'm 10 years later and I'm actually off them for the first time. So there's hope that I think maybe I may not need to go back on them. And that's always nice to hear if someone says it might be lifelong meds. It's quite a scary thought, but kind of with trial and error through my team at the moment, I'm just deciding, okay, well, this is right for me right now. And then if I do decide I need to go back on them because I'm not well again, or because I need that stability, then they can help me with that as well.
So I guess that you are in a good position to contribute to inform decisions about your management, because you are more aware now. You got information through the Pituitary Foundation, through probably other sources. So you became empowered by knowing more about the prolactinoma, isn't it?
Yeah, that's right. And I think the more I knew, the more I became less scared, because I had all this information from the help of the foundation and people like yourself, Niki, who were able to speak to me and kind of break it down. You know, like I said, or what, like you said, when you hear brain tumor, that is terrifying. But when you break it down and you research and you find out information online and through the charity, that's when it becomes less scary and more manageable. And that's where I am now, like 10 years on. Like I'm not scared by it. And if I had someone that came to me, which I quite often do, I get some people message me on Instagram saying, oh my God, Jess, I've read your blog. Like I've got the same thing as you. You helped me see that, and you helped me make me realize it's not super scary. So that fills my heart with so much joy. It's so lovely to receive messages like that, because I know if I had someone 10 years ago, I would have felt so lucky to be able to reach out to someone and speak to someone that was maybe going through the same thing.
Sherwin, any question?
So really, in terms of your treatment, when you first started on treatment, because this is common in endocrinology where patients will be given a treatment. So were there anything that scared you the most that you wouldn't want people to go through when you were told that you need to start on treatment?
Yeah, I think I wasn't scared about the medication, because I thought tablets is something that I can manage and it's manageable for me. I do remember Niki saying that the other option would be to do surgery, and that would obviously involve I think going through the nose to reach the pituitary gland, and that was something I really didn't want to do. Like that terrified me, and I was really scared about that. So to avoid having to deal with that, my first thought was, well, let's go with medication, because I'd much rather do that than have invasive surgery. I know not everybody has that option, because I understand people's prolactinomas can be a lot bigger and therefore need to be removed. I totally understand that. But I think that for me was the most scary part, because that made me kind of, take a step back, and I was quite worried about that. But having the option to do the medication was great for me, and it's worked for me. It might not work for everyone, but for me, I was much more at ease with that.
Excellent. That's good.
And my understanding is that you have been in touch with other patients who have the same condition. Have you spoken with any males who have a prolactinoma? Any men with a prolactinoma? Or your contacts are more...
That's really interesting. I've only ever...
Yeah, so Jess, go.
Yeah, so... Thank you. So mainly female. I met one man at my local support group in Oxford when we were allowed to do face-to-face chats and not Zoom ones. And he had a prolactinoma as well. And he said he had no idea what was going on. I can't remember if he had the lactation or whether it was just the blood test that was showing the high level. He's the only man I've ever met, only one, and the rest have been female. Some I've met in person at events, and some I've just spoken to online and I've met online and just had conversations and chats with them. But majority are female, which I think is really across the board. I think the female is obviously, it's obviously more common in females, but it's really interesting. Have you come across many male patients lately, or is that something that's historically female?
For microprolactinoma, small ones, they dominate in women, and we will discuss this in a couple of slides we have later, or they are more commonly diagnosed in women. And the main reason is because if the tumor is small, it doesn't cause substantial pressure effects. So the only manifestations we would expect is those of hypogonadism, low testosterone in males, or problems with the periods or lactation in females. And women will pick it up because periods become irregular or they stop. Whereas in a male, if we are dealing with low testosterone, sometimes these symptoms, these manifestations can be overlooked, and the male can attribute them to tiredness or lifestyle or whatever. So diagnosis is not early, and actually in males, the prolactinomas that we diagnose are big enough. They have become big enough to cause pressure effects and cause problems with the vision. So your experience that you have shared your history and your feelings and your experience mainly with females goes with the epidemiological data we have about prolactinomas. So what you say is very, very sensible. And so how long do you expect, if you were to restart cabergoline, okay, how long do you expect to be on this treatment? Any ideas, thoughts?
I think until I decide I want to try for a family, and then I would come off it and assess what my options are. For me right now, I think probably a couple of years until I then decide what I want to do. But it's just depend. It's really dependent on when I decide that, really. And I think it will probably be a few years before I make that decision. But I wanted to at least kind of try it before I get to the point of like, right now I want to have a child, because now I've been off the tablets since last August, so just over a year and a bit now, and myself, I'm feeling really well and healthy, and I really thought I would go back to square one. I thought it would be awful, and it's actually been okay. So yes, my levels have gone up. My blood tests have shown that the prolactin levels have gone up sort of slightly, but nowhere near what they were at diagnosis 10 years ago. So I think I have to make that decision based on my MRI results and when I've got a bit more information on that. But if I were to restart them in the next 3 months, I would say probably the next year, couple of years, I would be back on the tablets, and then assess at that point at what point I am in my life, if I want to carry on or want to stop for a while and try for children.
And let's take the beautiful scenario that in a few years you have a couple of kids, a happy mom, maybe you have restarted cabergoline. So what is your expectation for the long-term treatment with cabergoline? Would you expect that you will continue this forever, or at some stage this could be stopped? Any idea, any information you may have, any worries, any thoughts about that from your side as a patient?
Yeah, to be honest, I feel if I was done with having children, I would then go back on it. I'd go back on it after having my first baby, because I know I would want to be well in myself, and I have been fine for the last year, but my hormones might be so different after having a child that I would think, okay, now is a really good time to restart the medication. For me, that will probably mean long-term being on it for 20, 30 years, maybe until menopause age. I don't know. I don't really know how long we're advised to be on the same medication, or whether as I get older, my prolactin levels might even out. If the tumour has stopped growing, which hopefully this MRI shows it has, at least then I will know whether or not it would be a good time to sort of stay off it, and hopefully I might not need to go back on the tablets. But I envisage after having children I would certainly need to go back on it. I'm not sure for what length of time, but I imagine it would be quite a long time.
So you raise a very interesting point. So there are some scenarios, some settings in which we can stop the cabergoline. Obviously we have other type of the same family of drugs that we can use, but cabergoline is more frequently used for various reasons. And one scenario is menopause. So if a lady reaches menopause, the high prolactin, if it is, of course, a small tumor that we are not worried that this could expand and cause pressure effects. So if it is a small tumor, a very small tumor, we can even stop the cabergoline, because high prolactin would not affect the ovaries anymore, because after menopause, ovaries are not producing estrogens, and there is no obviously ovulation. So that's one scenario. Another scenario that we will cover later is that we have seen that on a number of women after pregnancy, prolactin levels remain normal for a very long time. There are various mechanisms that this happens. We will hopefully cover them later, but that's another setting we need to consider. So there are cases in which for a woman, we can consider stopping the cabergoline, the dopamine agonist, that's what the drug is called, the family of the drugs is called, and we can stop it without any consequences for our patient. So that's something we need to think of. And I think Sherwin has raised his hand. So Sherwin.
So Niki, Jessica has raised this really interesting point, which is normally comes out in clinic. Just for the sake of the audience in here, are you able to explain why, like Jessica, on patients who've been on treatment for a couple of years or so, and they decide to stop because they want to achieve pregnancy, why the prolactin doesn't go anywhere near as the baseline prolactin level before they started treatment? Because this is the question I always get from patients of childbearing age. They've been in treatment for 2 or 3 years. They want to have babies. They worry that their prolactin level will go to 100,000 again. So just for understanding of those people, why do you think those prolactin doesn't go anywhere near? In some cases it might go to the baseline, but majority of the cases being on treatment for several years, why they don't go anywhere near that baseline?
Is that for Niki? I feel like that would be a Niki question.
That's for me. Okay. Well, first of all, it doesn't go near to the baseline because we don't allow it go near to the baseline. Okay. If we see the prolactin going up, shooting up, and the patient needs treatment, we will obviously restart it. So we don't know if we left the patient off cabergoline for 2, 3, 4, 5 years, what will happen if the prolactin starts rising? That's number one. Number two, cabergoline itself affects the tumor cells, and it can shrink the tumor. It can affect the function of the tumor cells, and as a result of this, the activity of the tumor may be less after a few years with treatment with cabergoline. That's the main reason. So cabergoline has this magic action of not only reducing or normalizing the prolactin, but also shrinking the tumor. And that's why pressure effects that we may come across, like visual deterioration as an example, they improve or even resolve with the treatment with cabergoline. And it's an amazing experience, I would say, that we have as medics, to see the vision of the patient coming back to normal with a couple of tablets. And this replaces surgery, actually, which is another advantage.
Yeah, thanks, Niki. That's the reason why I asked is I literally saw a patient today in clinic where we started treatment many years ago, and then she started to stop treatment, and then her prolactin for several years is just hovering in hundreds. And then she's questioning me whether did she really need to start treatment, because now that she's not on treatment, her prolactin is not in 10,000. So, and Niki has explained it clearly, you know, the cabergoline shrinks the tumor, and over time, they're not as actively functioning as prior to you starting the treatment. So, and as Niki said, we will not gonna leave you with your prolactin creeping up. Even though you're not on treatment, we will constantly monitor you to make sure that we don't go to that state where, the state you were prior to you starting the treatment.
And I would like to make another point about the cabergoline. And of course, yes, as I said, we have other medications of the same family that can be given in prolactinomas. We like cabergoline because of its efficacy, and I'll show you some data later. And another important point, which I think is important for the quality of the life of the patients, is that it can be offered once or twice per week, whereas the other medications need to be offered daily and sometimes 2 or 3 times daily. And this is something that we as healthcare professionals may not consider as an important point in the care of the patient. But I think for the patient, it does matter. It does matter if they have to remember to take drugs 2 or 3 times per day or once or twice per week. So any thoughts about that, Jessica? Quality of life and regimes of treatment that we offer.
Yeah, absolutely. I was on 0.5 milligrams, so half a tablet a week, which is a very small dose and very easy for me to just remember, take it on a Sunday, you know, take it once a week, not impactful on my day-to-day life. You know, people at work wouldn't see me quickly taking 2 tablets a day or anything. I think for me that was really nice, because actually I kind of forgot that anything was wrong really. It was just once a week I took this tiny little tablet and that was it. It didn't impact my life in a massive way. And I also think in terms of how I was looked after during my diagnosis and after my diagnosis, my trips to the doctors were probably, you know, maximum blood tests every 6 months, which was fine, you know, sometimes 3 months, but normally every 6 months. It was normally every 9 months to go and do the visual field tests at the eye hospital. And then I didn't have an MRI until last month, and the other one was like 2014, I think. So it's very manageable in terms of, you know, I was seeing getting the blood test done every 3 to 6 months and getting the eye hospital done every 9 months. It's really not a massive invasion of your life when there are people who have to go through a lot to have a lot of medication and a lot of recurring hospital appointments. I felt quite lucky that I actually only had to go sort of every so often, as opposed to something that was weekly or daily or encroaching massively on my life. So yeah, I agree with that, definitely.
Yeah. Sherwin, any point, any question?
No. So just really pointing that on the other end of the spectrum, we also see patients wherein the thing with tablets that are not daily, you will see a small number of patients wherein it doesn't become part of their normal routine, is it? Unlike the daily. So in those cases, I always tell patients, we need to use the technology. So you have your phone, set a reminder on your phone, because as Niki said, in some cases, you only need to take it once a week, and it can easily be forgotten, especially those working adults. And we see that a lot in clinic, and Niki will agree that we can tell several years ago, your prolactin is normal, and all of a sudden this year, it became slightly high. And, you know, you can tell by asking the patient, oh, I've been going on holiday, I've got a new job and things like that. So if you want to maintain that control, because it is a condition that we can control effectively in most conditions with a tablet, so really complying with that medication is important. And, you know, assistance from, now that we have iPhone 14, and I'm sure most of you got an iPhone 14 with loads of different functionalities. So use the technologies that you have in reminding you when to take those tablets that are not a daily tablet as well. Yeah.
Thank you, Sherwin. So a final advice or comment to other newly diagnosed patients, Jess?
I think the advice would just be to get as much information as possible, and whether that's looking at online information, blogs. There's lots of people that I follow who have a really similar condition or the same one, pituitary related conditions in particular. Because of the foundation, I feel that online presence has rocketed in the last 10 years. I definitely think the use of social media has really helped. We're different to what we were in 2011 when I didn't have anything. I don't think I even had Instagram then. So it wasn't really a thing. So now we have so much information at our fingertips. If I was to be diagnosed today, I think I would feel kind of reassured that there are people that have gone through this and that I'm not alone. And I think if I was newly diagnosed, I'd just reach out as much as possible to people. It's so nice to speak to people. We've had such an awful time with COVID. To speak to people in real life, to get information, to speak to the nurse helpline at the foundation, which is a fantastic service that maybe people might not know about. You're talking to a human, you're getting support, to talk to your consultants like Niki, like yourself, like Sherwin, to speak to people in the hospitals. I think just ask questions as well, I would say, because I probably was quite scared at the time and didn't know a lot and didn't really think to ask questions. It was only after sort of various consultations and doctor's appointments, I kind of wrote stuff down and took them to my next appointment. So maybe in hindsight, I should have tried to be a bit more kind of vocal with asking lots of questions. But I would say that there is help out there. There is so many fantastic sources and people that can help you, and you're not alone in this at all. You know, there are lots of people to speak to, so I would hate for people to feel lonely and quite vulnerable. It's something that can also, if it's managed correctly, like mine has been, I've had a really healthy full life and I haven't let it stop me. So there's lots of reasons. I know would be a scary time, but there's lots of reasons to feel positive if you're able to get past that. I understand it's hard, but yeah.
Great, thank you, Jess. Jay, I don't know if you have any question.
I don't. I'd just like to say thanks, I would, Jess, for bravely sharing your story. Really, really appreciate it. And I feel honoured to be facilitating this for your here with the person who diagnosed you.
I know. It's really nice. It's really nice to be on the same screen. It's crazy.
Yes. Absolutely. So I just wonder whether we show some slides and then we go for questions and answers by our attendees or Jess or the team from our Pituitary Foundation. Shall we do that?
Yeah.
Okay. I will share screen. Great. Am I sharing screen?
Yeah.
Okay. Let me just make it full screen for the slides. Okay, so just a few pieces of information on prolactinomas, and I will cover the journey from diagnosis until long-term management. And so how does the diagnosis start? Yes, it may sound straightforward when we have the final diagnosis, but we have to accept that it's not only the journey of the patient long, the diagnostic and the differential diagnostic thoughts that a medic has to put in can also be relatively complex. Why am I saying that? Because we have a patient with symptoms and signs of high prolactin, which I will show you in a second, and we measure a prolactin. And then we have this value, which is above the reference range. And then this value, this piece of paper or the electronic record nowadays is thrown on the desk of a medic, and this medic or the healthcare professional has to understand what is going on. So a few points that I want to raise here. First of all, prolactin is a hormone which increases during stress. And even the venipuncture stress can increase the prolactin. So what we need to do is to have one sample, but this doesn't mean that the prolactin, especially if it is borderline, is of clinical significance. We need to repeat the sample and make sure that this is a true finding. A second point is that sometimes we have problems with the measurement of this hormone. We have what we call macroprolactin, and I will not go into detail, but macroprolactin is when we are dealing with high levels of prolactin, when in reality, these high levels don't cause a problem. Okay. And there are specific ways that a lab, a biochemistry lab, can tell us if this high number of prolactin, high value of prolactin we have is true prolactin or macroprolactin. So this has to be looked at. Then we need to speak with our patient and see, does this patient have manifestations of high prolactin? Because we are not treating a number, we are not treating a value of prolactin, we are treating a human being, and we want to know if this number, this value causes problems. We need to ask about drugs, because there are a number of medications which can increase the prolactin. We need to examine, to do physical examination of the patient. Example, check visual fields, look at breast discharge, galactoria as we call it. In women of the reproductive age, especially if the periods have stopped because of the high prolactin, we need to do a pregnancy test. We don't want to start investigating a woman for a high prolactin when actually we are dealing with a very happy event of pregnancy. Liver or kidney dysfunction can cause high prolactin. Polycystic ovarian syndrome can cause high prolactin, and underactive thyroid, which is not treated, can cause high prolactin. So we have to think about this before we start thinking of a prolactinoma. So if we exclude other causes, then either we are dealing with a prolactinoma or with another tumor in the area that the pituitary gland is, or the hypothalamus, which controls the pituitary, which can cause high prolactin. And of course, we will do imaging, and then the prolactin levels, how high they are, will guide us as to whether we are dealing with a prolactinoma. And another issue that we need to discuss with our biochemistry, because biochemistry is our right hand when we investigate hyperprolactinemia, is to see if there is a phenomenon which we call hook effect, in which, again, for some reason, technical reason, the patient has a large tumor which secretes prolactin, too much prolactin, but for some reason the lab gives us low values. So we have to discuss this with biochemistry. So the journey of the healthcare professional is equally long until we end up with a diagnosis. And a few things about the epidemiology of prolactinomas, because we go straight ahead to prolactinomas, we forget about the differential diagnosis, the other differential diagnosis. What's the prevalence? These are UK data, which we had published with Professor Walsh when I was in Oxford, and with a wonderful fellow we had at that time, Alberto Fernandez, who is now a professor of endocrinology in Spain. So the prevalence is 44 cases per 100,000 people, still a relatively rare, I would say, condition. In terms of sex ratio, they are much more common in women, as we said. This is the ratio. In terms of age diagnosis, the median age is around 30s. As you can see, in males, they are diagnosed later compared with women, for the reasons I mentioned before, because women usually lose their periods or they have menstrual irregularities, irregular periods, and this will trigger visit to the GP and further tests. And in terms of duration of symptoms, they are generally around 1.5 year median, but this could range between half a year to even 12 years. And prolactinomas are the most common pituitary tumors. This is the distribution we have. And most common pituitary tumors in women, but they are the second most common pituitary tumors in men. So these are epidemiological data from the UK. How do they present, these tumors? They present with manifestations of what we call hypogonadism. Hypogonadism means that the gonads, the ovaries or the testes, don't work as they should. And this is because the prolactin reduces the stimuli that go from the pituitary gland to the gonads to make them work as they should, produce testosterone or estrogens, and obviously fertility, sperm production or ovulation. So men could have tiredness, low libido, they can have pressure effects because of the tumor, headaches, visual loss. In women, problems with their periods, breast discharge, again, headaches, problems with their fertility, tiredness. And the majority of these tumors tend to be small ones, what we call microadenomas. Micro means below 1 centimeter. Another interesting scenario that we can come across is if this tumor not only secretes prolactin, too much prolactin, but also it secretes too much growth hormone. We have such entities, we have such tumors. So when we check a prolactin, amongst other things, we need to check the IGF-1. It's another hormone which shows how is growth hormone secreted in the body. And management, I would put here if treatment is needed, because sometimes prolactin may be high, but it doesn't cause consequences. So the first line option is a dopamine agonist. These magic drugs which act at the receptors, at areas, at binding sites in the tumor, on the tumor, and they normalize or reduce prolactin, they reduce the tumor size, and of course, as a result of this, we have restoration of the gonadal function. This family includes the cabergoline, which we discussed so much today, bromocriptine, pergolide, quinagoline. We mainly use cabergoline in our practice. And the action of the dopamine agonist, if the tumor is responsive, is really, really rapid. Prolactin starts decreasing within a few hours, couple of hours, because it has a short half-life, and it normalizes within weeks or months. The reduction in tumor size also starts very quickly, and if the patient had presented with visual field defects, as I mentioned earlier, there is improvement even within 1 week. It's so impressive to see the visual fields before and the visual fields after a week. And the shrinkage of the tumor continues for until at least a year. So shrinkage does go on. And our approach for the management of a prolactinoma, which, as I said, a microprolactinoma, which, as I said, are more common in women, depends on a number of factors. Obviously, if we need to start treatment, we will start dopamine agonist, usually on a higher dose, and then later when things settle, we reduce it. If we don't offer treatment, there are some data, old I have to say, which suggest that 5 or 10% of the tumors will progress without treatment. Then there are two groups of women, of patients, who may not need dopamine agonists. We may get away without offering this treatment. And this could be women who are premenopausal, who have regular cycles, i.e. ovulation is not a problem, and they have breast discharge, which is tolerable. It doesn't disturb them. And also in postmenopausal women who may have breast discharge, but again, it doesn't bother them. And here we monitor the prolactin. Another group is women who are before menopause. They don't have periods, but they are not interested in fertility. So in such a case, we could offer them estrogens, usually oral contraceptive pill or HRT, because we want to replace what is missing, because we want to protect their bones, we want to protect them from increased cardiovascular risk in the long term if they have premature menopause. And we monitor the prolactin. And of course, we do a scan if we have signs that the tumor has increased in size, like sudden headache or deterioration of vision, or if we see that the prolactin goes up despite treatment. That's about micro. Microprolactinoma is below 1 centimeter. How about the macroprolactinoma, which is above 1 centimeter? Again, we start with treatment, and at the Queen Elizabeth Hospital, we have a protocol for the titration of the dose, and this is done by Sherwin, who monitors closely the patients who are referred to us with a newly diagnosed prolactinoma. We start with a higher dose, we titrate it up, and then at some stage we start dropping it when prolactin has, and tumor shrinkage have happened, the prolactin has reduced or normalized basically, and tumor has shrunk. We monitor vision, we do scans because we want to see the tumor shrinking. And we have to remember that when the prolactin goes back to normal, we need to recheck the gonadal axis, testosterone, or in women it's easier if their periods come back, because after restoration of normal prolactin, the gonadal axis may come back to normal and people may not need replacement with testosterone or estrogens. And it seems in a study that we had done, based on a study we had done many years ago, that the reversal of other deficits in the pituitary gland because of a pressure by the tumor, it may be unlikely, but the gonadal function may reverse, and we need to keep this in mind when we look after our patient. Now, there is discussion, and probably some of you may be aware of this discussion about the impact of these agents, the dopamine agonists, on the heart. And probably some of you have had scans, echocardiogram scans of the heart, and follow-up scans of the heart. And this big noise started after a paper that was published a few years ago, many years ago, in one of the most prestigious journals we have in medicine, the New England Journal of Medicine. And this paper looked at problems with the heart, with the valves, in people who were taking these agents, the dopamine agonists, but these patients had Parkinson's disease. And in Parkinson's disease, we use very, very high doses of these medications, in contrast to prolactinoma patients where the dose is much lower. So this paper showed higher risk of fibrotic valve disease, problems with the valves, and obviously as a consequence of that, problems with the function of the heart. And a lot of studies followed from the UK, from other places around the world in patients with prolactinomas. And to cut the long story short, we ended up that the evidence that dopamine agonist treatment causes abnormal valve morphology and dysfunction at doses used in the management of hyperprolactinemia, prolactinoma patients, is extremely limited. The evidence of clinically significant valve pathology is absent, except for isolated case reports around which questions remain. So with this message, of course, despite this message, we have to be careful. So the British Society of Echocardiography, the British Heart Valve Society, and the society, our Society of Endocrinology, released the statement guidelines, and lead was William Drake, our colleague from Barts. They gave some recommendations on how we follow up patients in terms of echocardiogram and how often we do that. The message is that if the patient is on a dose above 2 milligrams per week, then we probably should do annual echocardiogram, although I think as years pass, we become more relaxed with this advice. Then another noise that has been generated about these drugs, and I don't know which of you have heard the term impulse control disorders. So dopamine agonists have been on a number of occasions be related with these disorders, which are characterized by a failure to resist an impulse, a drive, or a temptation to perform an act that is harmful to the individual or to the others, usually to the individuals. And the individuals experience this increased sense of tension before this act, and pleasure, gratification, or release of the tension at the time of committing the act. And what are these acts? It could be pathological gambling. It could be hypersexuality. It could be compulsive shopping, compulsive eating, just to name a few examples. And as you can imagine, the consequences for the patient and his environment can be really devastating, especially with gambling as an example. And there can be ethical and medical legal issues for the physician. So it has been shown that the greatest risk appears to be hypersexuality with strong male bias. And it seems that this develop regardless of doses of dopamine agonists we use or what kind of dopamine agonist. So if a patient has a previous history of impulse control disorder, we need to be very cautious when we use these medications. We need to counsel the patients, the families, the caregivers about this risk. And during follow-up visits, it's good if the patients and the family members are specifically questioned about that. And if we pick up impulse control disorder, which I think is not as common as it probably has been declared in the last few years, then either we reduce or stop the dopamine agonist, and this could ameliorate the impulse control disorder. Now, another scenario, the pregnancy, and we touched upon that. So what happens in pregnancy? Normal pituitary, the normal pituitary gland increases in size, and there is a risk of increasing the prolactinoma. If a lady has a macroprolactinoma, so a large tumor, we advise her to become pregnant, to try for pregnancy only after we have achieved normal prolactin and the tumor has shrunk significantly. Because if she becomes pregnant when we haven't done, when we haven't provided the benefit we want to give to the patient with medication, and having the pituitary increasing in size during pregnancy and even the tumor increasing in size, this could lead to problems during pregnancy. So once the lady confirms that she's pregnant and we are happy with that, we stop the dopamine agonist. And data now have accumulated which show that bromocriptine seems to be okay for patients. And we have a lot of data on cabergoline which show that probably it is also safe. And if we leave a lady with a microprolactinoma, so below 1 centimeter, without treatment during pregnancy, the risk of clinically relevant increase in the tumor is very, very low. And we monitor during pregnancy for headaches and visual deterioration. If the tumor is a macroprolactinoma, the risk of increase of symptomatic increase that could cause problems is higher. And we may continue with dopamine agonists. And again, we monitor this woman for headaches and visual deterioration. And if the enlargement causes symptoms, causes trouble, we restart dopamine agonist, or we go for surgery, or we go for delivery if it is close to that time. A question we may come across is from a lady who has a prolactinoma, can I breastfeed? Of course they can breastfeed, because this doesn't have an impact on tumor size. And as I mentioned earlier, there may be a curative effect of pregnancy for the prolactinoma. Then another scenario, which is thankfully not so often, dopamine agonist resistance. Yes, so these drugs can be magic, especially the cabergoline, but on a number of occasions, small number, this may not be effective. And how do we define resistance? We define there are variable criteria, but we use the Endocrine Society guideline. So failure to achieve normal prolactin on maximally tolerated doses of dopamine agonist, and failure to achieve more than 50% reduction in the tumor size. And the maximum tolerated doses again vary amongst patients. For cabergoline, it may be up to 12 milligrams per week, which is a really high dose, or 30 milligrams daily for bromocriptine. And these are numbers which show us the percentage of tumors which may be resistant to dopamine agonists. So you can see that for bromocriptine, the resistance is higher. For cabergoline, it's much lower. And this is one of the reasons we prefer cabergoline. Also, larger tumors tend to be more resistant to treatment. And it is more common for some reason in males. So resistance to dopamine agonist treatment. And the point I need to also raise is that we have a patient who has a high prolactin, still high prolactin, or prolactin starts going up. Before we start talking about dopamine agonist resistance, we need to ensure compliance. We need to make sure that the patient does take this medication in the way we had advised, because otherwise we just start increasing the dose of cabergoline with no reason. And how do we manage resistance? If it is true resistance, of course we have ways to manage it. Of course we have ways to deal with the problem. There are various options which can be used alone or in combination. So we can push up the dose of dopamine agonist, provided it is tolerated. We can change to another dopamine agonist. We could consider surgery, which is still in the algorithm of the management of prolactinomas. We could consider radiotherapy or combination of the above, or if the patient is not interested in fertility, we don't change the treatment, we just monitor and we offer gonadal hormone replacement, testosterone or estrogens. And thankfully, this is a rare scenario. We can have aggressive cases, tumors which continue growing despite treatment and despite compliance to treatment. Then management in centers of expertise is needed, where we can use various agents, even a drug which is a chemotherapy nowadays, the temozolomide. And then how about stopping the dopamine agonist? And Jess touched upon that. From time to time, we could consider stopping it and see what happens. However, there is a high risk that the prolactin will come up after stopping the treatment. Usually this happens within 1 year. The recommendation is to consider stopping it or withdrawing it if the patient has been on treatment for at least 2 years on a low dose of dopamine agonist, and the patient should have normal prolactin and preferably not visible tumor remnant. And of course, we keep monitoring things with prolactin at regular intervals, and we do an MRI if the prolactin increases. And I think Jess' story confirms this protocol I present you. A couple of more words on pregnancy, because as I said, prolactinomas are diagnosed in women of the reproductive age. So if a woman is pregnant, as I said, we stop the cabergoline when we pick up the pregnancy, when we confirm. And after delivery, and this is a quite interesting rate in studies, 12 to 70% of the women may have normal prolactin for a long time. Why prolactin normalizes during pregnancy? There are various scenarios. We can't prove anything, but it may be that the tumor undergoes necrosis, so parts of the tumor die, or this abrupt cessation of estrogen stimulation after delivery may lead to this apoplectic phenomena. And again, if a woman has become pregnant and has delivered, and we measure the prolactin, we monitor the prolactin after delivery, and stopping breastfeeding, of course, if she breastfeeds, because breastfeeding increases prolactin, and then we would restart the dopamine agonist if we see that the prolactin goes up and causes problems. So if it is symptomatic hyperprolactinemia. A few words on menopause. If we stop dopamine agonists during menopause, prolactin can remain normal in a significant number of women. Again, predictors for having a normal prolactin, for retaining a normal prolactin after menopause, if we stop treatment, is the prolactin values within 12 months after dopamine agonist withdrawal. And again, we keep an eye on the prolactin. We had a couple of cases where prolactin went really high and tumor showed some increase in size, and we put the patients back on cabergoline, but we keep monitoring our patients. So in menopause, we need to consider dopamine agonist withdrawal in women with a very small tumor, microprolactinoma or a macroprolactinoma, which responded very well to treatment, and now it is very small or it doesn't appear at all on imaging, and we continue with surveillance. So these are the couple of points I wanted to touch upon about prolactinomas. So a couple of take-home messages. Prolactinomas are the most common pituitary adenomas. We have medications to deal with them, and that's the first-line treatment. What do we aim when we offer these drugs? We aim to normalize the prolactin, to reduce the tumor size, to restore the gonadal function. I want to emphasize the importance of protocols for the dopamine agonist administration. So how we titrate the dose, how we follow up the patient, consider the fact that after pregnancy, prolactin may remain normal. After menopause, we again may have normal prolactin, or we can nicely withdraw the treatment. And yes, we have cases in which drugs may not work, but still we have ways to deal with this scenario. And with this, I would like to thank you for your attention. To remind you the message of our Pituitary Foundation on Living Well and Pituitary Awareness Month. Obviously, the Pituitary Foundation is a charity, needs the fundraising, so any help is very welcome. And thank you for joining. These are important pieces of information about the Pituitary Foundation, the wonderful endocrine nurse helpline, the patient support helpline, because I think that if we share the problems, we just divide them and we make them smaller. Whereas if we don't, the problem, I think, expands and becomes bigger and starts eating us. So thank you very much for your attention. I'm stopping sharing, and I guess it's time for questions.
Thanks very much for that, Niki. That was a great presentation. So do we have any questions? If you'd like to raise your hand. Niki's iPhone. I'll just unmute you. If you want to unmute yourself, Niki.
Hiya.
Hi.
Hi, can you hear me?
Yeah.
Yeah, so I'm just wondering if I can ask Dr. Niki. I've had a prolactinoma now for 10 years. It has shrunk on medication. I've been off the medication now for 2 years, but the prolactin levels have gone back up. I've had a recent MRI scan that I'm waiting for the results for. Is it advisable to go back on the medication if the prolactin is still going up because I've got return of the symptoms?
Yeah, I'm on mute. Thank you for this question, Niki. The answer as to whether you go back on treatment depends on many factors. Depends on your age. It depends.
46.
Okay, so close to menopause, yeah. It depends on your symptoms. Is it lactation, galactoria, for example?
Yeah.
So if you feel that you have symptomatic hyperprolactinemia, then you could consider going back to the medical treatment. And
so
of
the
course,
main symptoms are migraine, fatigue, and small amounts of galactorrhea.
I'm not sure about the fatigue. Obviously, we don't know your history, so I wouldn't like to risk and make a comment on that, or the migraines. But the galactorrhea, the milk discharge, does relate with the high prolactin. If it disturbs you, because of course it doesn't kill, but it does disturb. It's a cosmetic issue and it can disturb. Then you could consider going back to cabergoline, and you could discuss this with your doctor.
Okay, thank you. So that's the appointment that I have on Friday. It's just to whether or not that decision is made.
Okay.
Thank you.
Thanks, Nikki. And the next question we have is from Claire Grint. So Claire, if you'd like to unmute yourself.
Hello, thank you for some great talks today. I just wanted to ask a question. I have a 3.5 centimeter macro prolactinoma, and I'd got diagnosed in July last year. So I've been on cabergoline now for a year and 3 months or something like that. My prolactin levels have gone down to the normal range, if anything, slightly on the lower side. And the tumour is starting to shrink down, which is great. My periods haven't returned, and they've said it's something due to something called potentially mass effect. And I just didn't know what that meant, and why it would be that they wouldn't come back, if that makes sense, even though my levels have returned.
So you have a macroprolactinoma at 3.5 centimeters. It's not a small tumor. And despite achieving normal prolactin and tumor shrinkage, periods have not come back. Sherwin, would you like to answer that?
Yeah.
You deal with so many patients with this scenario, mainly males, but yes. I think it could apply in females as well.
Thank you, Nikki. Yeah. So, sorry, what's the name?
Claire.
Hi, Claire. As Nikki shown to you in her presentation, and she discussed earlier, one of the effects of a large tumor, when we talk about mass effects, imagine your pituitary gland is sitting in a very tiny space within your brain. If you got a tumor growing in there, that tumor will compress on the normal pituitary gland. Yeah? And that's what we call the mass effect. So the volume and the mass that is developing inside your brain next to the pituitary gland is causing that symptoms. And one of the effects of that is preventing your normal pituitary gland from functioning, because it compresses that normal pituitary gland. Even if we shrink the tumor and it shrinks into a slightly smaller level, the effect, and Nikki presented in her presentation, that effect on the pituitary gland, which is the deficit on the hormone, and likely you're not producing what Nikki presented as the gonadal hormone, so the LH and FSH. In majority of the cases, it might not recover, or in some cases, it might not recover. So what your consultant is saying, the mass effect of your pituitary tumor is it damages, in a real sense, the ability of your pituitary gland to produce that gonadal hormone, the LH and FSH that controls your menstrual cycle. That if you are still within the premenopausal stage, so meaning you're still at the childbearing stage, there is something that can be done about that, because we can replace that hormone. Yeah. And there are hormones like hormone replacement therapy that can induce that withdrawal bleed for you. Okay. Yeah. But if you are on the postmenopausal stage already, then there's really not much treatment unless you are symptomatic from having low estrogen level, for example.
Yeah. No, I'm 35, and I unfortunately didn't discover this until the point where I wanted children, which is the issue.
Oh, right,
because obviously it's, a 3.5 centimeter tumor that they've already said to me that I'll need to carry on with cabergoline during anything.
So as Nikki said, your tumor is not small. It is a proper macro or big adenoma, and it's not surprising to see some of those effects and damage to your pituitary gland because of that compression to your normal pituitary gland. And again, you just have to have a discussion with your GP then if you are truly hypogonadal, meaning you're not producing that gonadal hormones, what hormone can be given to you in order to induce that cycle of period that you will be expecting.
Thank you.
I've had one message come through to me directly, and I can also see Phil Ash has got his hand raised. So if I read out the message that I've had, so as someone, they'd like to remain anonymous. So as someone who is close to someone with this illness, how can I support them? For Jessica, what support did you find helpful in your experience from people close to you?
Yeah, I think what I found the best really was the support I received from friends and family who were around me and who had no, who didn't really know what to do or how to help me or comfort me through it. It was just being there. It was literally, on my down days where I was just crying all the time, it was literally just being very upset. And, I needed someone to talk to, and that's at that point where friends and family came in, absolutely. But also, as well as that, like I mentioned many times, reaching out to the foundation, speaking to the charity, meeting people at events for fundraising. I can't stress how important it is to try and see people face to face, because that helped me enormously. But I just think, the biggest thing is to talk, because if you don't talk about it, it's very apt that, Mental Health Awareness Day was, I think, yesterday, and that people just need to talk about things. If they bottle things up, that I don't think it doesn't help. I think you just need to reach out to people, even if you can't really process it yourself because you have no idea how your feelings are going to impact you. You just need to reach out and talk to someone, and there is help available. Absolutely.
Thanks, Jess. And then Phil Ash has a question. If you'd like to unmute yourself, Phil.
Okay. Yeah, I have. Can you hear me, Jay?
Yeah.
Okay, that's fine. Yes, thanks, Nikki, Jay, Jessica. It's been helpful, very helpful. I've just got a brief hypothetical question. I had a prolactinoma. I had cabergoline. It did its wonderful stuff. And now I'm getting to the stage now where once a year, blood tests, all that sort of thing. But with cabergoline, being facetious and putting the cost aside, why can't I just take cabergoline for the rest of my life? It's a tiny little tablet. I have it twice, and it works. Why would I, putting aside the cost, why wouldn't I just carry on taking it forever?
So Phil, why are you asking that? Have you been told to stop it?
No, but I understand that obviously Jess went off it, and I understand, I do. We all look at Google, and some people say I was on it for 5 years and so forth. But then they have to have a check, and some people go back on again. I've seen these, these things. I've just put in a very general sense, just a few sentences. I don't really want to diagnose this, but why can't people just stay on it? So, you take the tablet twice a week. It's miraculous, and it just, there's no risk there. It's always attacking the tumor. I'm not a scientist, but it's always attacking the tumor, looking after me. Why stop? I have no side effects.
Okay, the answer to this will be with another question. If you can stop it, if you don't need it, why should you continue on that?
Well, there's this grey area that I have read somewhere, and we're all doctors through Google, aren't we? That sometimes it comes back, and then you have to get back on it again.
Mm-hmm. Yes.
Yeah, and perhaps it comes back before the blood test that shows that. So I'm just thinking, well, why not just keep it as preventative maintenance, as it were, forever?
It depends on the patient. If we are dealing with a microprolactinoma, a very small tumor,
yes,
which has responded nicely to treatment, and we stop the cabergoline at the right time. We are not in a hurry to stop it when all the criteria are fulfilled. Yes. So there is a possibility that things go well for many, many years. Mm-hmm. So why should the patient be on a treatment that they don't need it?
Okay.
And for you, it may be okay, 1 tablet per week, 2 tablets per week. For someone else, this 1 or 2 tablets per week may be a nuisance. Yes. So every human being is different.
Mm-hmm.
And Nikki, I'm sure you will agree. majority of the patients who stop treatment, the reason for stopping is actually driven on the patient side. So it's either patient choice or a contraindication for patient to continue treatment. And in like, for example, in Jessica's case, it is Jessica's choice to stop that treatment. So mostly it's triggered by patient questioning, can I stop this treatment? I've been this for 10 years and I've been finding it difficult now. I'm I'm already 80 years old. I can do without, with reducing my tablets. So to answer that question, Phil, majority of the cases, we will usually be guided by the patient. And in some cases, we will put that option to the patient if we think that it's the right time, because the patient has been on treatment for 10, 15 years and we can see that prolactin is undetectable. But again, with any of that treatment, as Niki mentioned in her presentation, we wouldn't just leave the patient unattended if we decided to stop the treatment.
Thank you.
Thanks, Sherwin. I can see we've got the last two questions here, so I think if we can just squeeze these in.
Guys, can you ring her? Because she's texted us, I'm busy.
So just... Thanks, Niki. So we've got a first question came in from Juliana, and then Kirsty Nixon also has a question. But if these are the last questions, folks, because I'm mindful of time.
Yeah, hello everyone. I'm Juliana. So yeah, my question is more regarding. I was diagnosed last year with a microprolactinoma, and I had all the tests and stuff, all the follow-ups, but so 5 months ago, perhaps, I had like a follow-up with my endocrinologist, and basically the levels reduced a bit. And he said, we are going to wait how the body responds to not taking the medication. So let's wait for like 2 months or 3 months. And but my symptoms have gone back again, and I reach out to my consultant to try to ask for what is going on. And he said, I need to take the medication again, but I haven't been able to receive any follow-up from any doctors or a response from the hospital, the NHS, or the GP. Well, the GP is not even aware that I'm suffering of this. So it's a bit frustrating because in the meantime, I have to deal with all the symptoms again. And I also have a galactorrhea. So yeah, it's a bit difficult to manage. So I don't know if there is any advice from you guys in terms of how to reach out to these kind of situations to try to get the medication or a follow-up from the consultant.
I think if I may just jump to give an answer, obviously this is an admin issue, which is important for you, for your health. Yeah. I would have thought that the best way is to contact your consultant through their secretary. That's how we are contacted as healthcare professionals. I'm not sure if I can provide any further advice on that. It's a problem of the system, I would have thought, rather than...
yeah, I think it is also kind of a problem after the pandemic. It's more difficult to try to get appointments and stuff.
Sure. I mean, yeah, we are sorry that this happened. I mean, pandemic has affected everything in the healthcare system. But I guess the best way is contact your consultant through their secretary, through the admin team. And I would have thought that I'm pretty sure our colleagues will come back. We don't want our patients to suffer.
Yeah, of course. Thank you very much anyway. This is really helpful. Thank you very much.
And then final question before we wrap up. So Kirsty Nixon, if you'd like to unmute yourself.
Hi, thank you so much for this evening. Just to summarise my story, I was diagnosed with a microprolactinoma in 2017 as part of quite a lengthy fertility journey, which resulted in my daughter being born last November. I've since gone back on bromocriptine, which is what I've been on since 2017, and it did halve the size of the tumour. But from listening today, should I be asking to be switched to cabergoline? And I do suffer with quite bad side effects from bromocriptine, the nausea, dizziness, and I take it every day, 5 milligrams a day. would it be more beneficial to be on cabergoline?
So our understanding is that there has been response to treatment, i.e. normal prolactin, isn't it?
Yes.
The resolution of the consequences of the high prolactin. You have a microprolactinoma, so the drug has worked. However, our understanding is that you have some side effects on this agent.
Yes.
Yeah. So this could be an indication to discuss with your consultant to try another medication which could cause less side effects. And of course, if you change to something else, it may equally cause problems. But if you have side effects which compromise your quality of life, or they are related with even more problems, then it would be worthwhile speaking with your consultant.
Okay.
Thanks, Nikki. And thank you for tuning in, everyone. Really appreciate you joining us. Thank you to Sherwin, Nikki and Jessica for being absolutely excellent. I said you were in for a treat this evening, so thank you to the three of you. And thank you to all of you who've joined us and taken the time to ask you questions. All of us, as I said, all of our sessions will be available to watch on YouTube and on our website at a later date. Please feel free to head over to our social media channels and to our websites to see the sessions available, as well as some more resources at www.pituitary.org.uk. We're proud to be able to bring this month's worth of different informative workshops and online sessions for free, but we do rely heavily on the kind donations of supporters. If you found this session useful and are able to do so, please do consider donating to the Pituitary Foundation by texting Living Well 10 to 70085 to donate £10. Texts cost £10 plus one standard text message rate. And don't forget to check out the rest of the Awareness Month programme on our website, and you can get tickets at buytickets.at/the Pituitary Foundation. Thank you, and we hope to see you again soon at some of our other sessions. Good evening, everyone. Thank you.
Thank
Bye-bye.
you. Thanks, everybody. Thanks. All the best.
All the best, everyone. Thanks very much.
Thanks, everyone. Bye.
It's nice
Bye-bye.
to see you.
You too. Thank you, Nikki. Take care.
Take care. Bye.